Hey guys, today we're going to be talking about the patient with HIV or AIDS, and all you need to do is to follow along here. I'm going to try to keep this under 15 minutes, so we'll be going through some of these slides really fast, but you can pause this at any time. It's kind of handy. So for those of you who aren't familiar with this type of a delivery system, it's just like any other video. You can pause it, forward it, rewind it, and you've got the slides that we'll be discussing available. And yeah, it's in some ways better than the real deal because in class you can't pause me. Here you can. All right, so I'm going to put us into slideshow view. And of course, we're talking about the patient with AIDS. This here is actually, I updated the material. It is spring 2013. And the questions come up of why do you need to know? And of course, the first thing we think of is disease transmission. We've already talked about that at length first semester as far as how to prevent transmission, but that's one of the most important reasons why we need to understand HIV virus. The second is that we do have patients that are HIV positive in our clinical practice, and you may very well have some patients that are HIV positive in your future practices. There are also a few oral manifestations of HIV positive status and full-blown AIDS that you need to be aware of. You might have studied those in pathology. It seems like I heard that you'd talked about a few of them, at least the HIV positive and AIDS-related NUG. And then there are oral conditions in care of the HIV positive or AIDS patients that you need to be aware of. So those are the whys. Here are the what. There's a couple pages of objectives, and you can read those yourself. This will all be covered in these slides here. The first thing that you need to pay attention to is to know the difference between the fluids that have demonstrated transmission of HIV and those that have not. Those make for perfect test questions. There are 4 that have demonstrated transmission, and then there's 4 that have been found in the different fluids but have not been demonstrated to transmit. Not enough of the viral load has been found in 4 other secretions that have demonstrated that they actually do transmit. So first of all, the 4 that do transmit, that have been demonstrated to transmit, are blood, semen, vaginal secretions, and breast milk. Okay, these 4 here, the virus has been found in, but they have not demonstrated transmission yet at the time of this writing. They haven't been proven to actually transmit, although the HIV virus has been found in them. So be sure you understand the difference between being detectable and being evidence of transmissible. And that's saliva, tears, urine, and bronchial secretions. Going back to this, if saliva, a question I would ask if I were there with you is, what if saliva hasn't been demonstrated to transmit HIV, why are we so worried about contamination of saliva for us as healthcare providers? And I would hope that your answer that would come to mind would be 2 reasons. First of all, we're not just worried about HIV. There are other diseases that are transmitted via saliva. But the second is, if you would remember our video, if saliva were red, back at the first of the first semester, remember that saliva is loaded with blood often, and sometimes you don't see it because it's diluted, but there is blood in there. And so what we're really protecting from as far as HIV, when we talk about gloves and all of our precautions, we're protecting against saliva, but we're also protecting against the bloodborne pathogens in the saliva. So our prevention of transmission, we've already covered that ad nauseum. Suffice it to say that there's 3 ways that we can help prevent transmission of HIV. The first is the interruption of transmission. If you recall, our personal protective equipment, our sterilization methods, those can interrupt the transmission. They protect the clinician and they protect the patient. Okay, the next thing that you'll need to know for testing purposes is the 5 modes of transmission. And these are pretty straightforward. There's sexual contact, blood products, occupational accident, exposure injuries, which, that's us. Perinatal virus transmission. There's 2 ways, note in number 4, 2 ways that perinatally are considered perinatal transmission of HIV. The first is across the placenta during pregnancy. The second is through delivery within an infected genital tract. So as they're passing through vaginally for birth, they can contract HIV if mom's HIV positive. And then postnatally through breast milk. Here's a list of individuals at high risk. It covers a lot of groups. Sorry. You need to know those groups, and those are pretty self-explanatory also. The sexually active. At the time that Wilkins printed, homosexual and bisexual men were at high risk. Heterosexual women and men have closed in on this, so they, a couple of years ago, had actually surpassed homosexual and bisexual men as far as risk. I don't know where they stand right at this day, so you don't need to have these in order. I don't have them in any particular order here, but you do need to know these 8. So sexually active, multiple partners, IV drug users, recipients of blood transfusions or blood products prior to 1985. HIV was not being screened for blood transfusion materials until 1985. Prostitutes, infants born to HIV-infected mothers or breastfed. That goes back to the transmission in the slide before. Healthcare workers who do not adhere strict barrier procedures and follow bloodborne precautions. That's not us, hopefully. And then steady sexual partners of any of the above. Or partners of such. Okay, as far as the life cycle of HIV, there's some complicated videos or some videos that try to make it look more simple than it is. For us, all we really need to understand are a few key points. Excuse me. The HIV is classified as a retrovirus. I put that in blue because you need to remember that. And so RNA, not DNA, RNA is the core genetic material of the HIV virus. And then you need to remember the enzyme reverse transcriptase is essential for replication or for repeating its growth. And its life cycle is divided into 2 phases, the establishment of infection and the production of new virus particles. We're going to talk about that here in a minute. Okay, so here's phase 1. HIV enters the body and circulates in the blood, and the virus attaches to target cells that have CD4 plus receptors. And taking you back to maybe microbiology or biology, if you recall, it's usually a T cell that has CD4 receptors, and this has got a nice little picture of it. Okay, so the virus attaches to a T cell, and then it injects its viral RNA, its HIV RNA, and enzymes into the cell. So here it is, it's injected the RNA into the cell. Okay, then you get that reverse transcriptionase or transcriptase, that's the enzyme. The viral 2-strand RNA starts out as 2-strand, this is ribonucleic acid, but just remember RNA, is changed into a single-stranded DNA. So remember that 2-stranded RNA is injected into the T cell, and then it's changed into a single-stranded DNA by the enzyme reverse transcriptase. I always think of this as a zipper and then it unzips it for some reason, just as a reverse transcriptase. It's how it looks on a video. Okay, and so then another enzyme, ribonuclease, destroys the RNA. So now what you're left with is a single-stranded DNA inside the cell. Okay, and that's when infection is considered established, once the viral DNA enters that host cell. So to simplify this, RNA is inserted into the T cell, or the cell, is changed by reverse transcriptase into single-stranded DNA, and at that point, HIV infection is considered established, or the cell infection stage is considered established. And then the subsequent progeny of the host cell are HIV-1 infected. So as they continue to breed, for lack of a better word, and to progress, those subsequent cells are HIV infected. Okay, phase 2 is a production of the new virus. So now you've got the DNA of the infected host cells forming new viral RNA and protein. And then multiple copies of the HIV positive RNA is incorporated into a protein capsule. You can see here again this picture, it's in a protein capsule. The virus itself lyses or dissolves the cell, and then that allows it to enter the circulation to infect another T cell. And then the series begins again. So it's now been lysed, is out into the circulation, infects another T cell by injecting double-stranded RNA, and which is changed again to single-stranded DNA through the reverse transcriptase process and enzyme. So that's that in a nutshell. Okay, the next thing that you need to know is what happens to those cells once they are infected. Well, they lose their normal function, and here are some key points. The destruction and reduced number of host CD4 plus cells equals immune suppression. These CD4 plus cells, most of them are T cells. When they are reduced through this viral process, that is what causes immunosuppression, and so which leads to AIDS. I'm sure most of you know AIDS stands for autoimmune depressive disorder. So it is a disease of immunosuppression. Okay, and this other thing that you need to pay attention to is that the decrease in the number of CD4 plus cells does correlate with the risk and severity of HIV illness. So in other words, the lower that the CD4 cells go, the higher the risk of transmission and the increased severity of the onset and symptoms and outcomes of full-blown AIDS. And that's how AIDS develops. These CD4 cells continue to decrease, and the increased risk and severity goes up along with that. It's a little tricky, and you need to be sure and get straight in your minds. We've got a few different codes and numbers going on here. We've got CD4 plus, and this plus always makes me think of higher, just added upon. But remember that it's when the CD4 plus is lower that you have the increased HIV plus or HIV positive status. Those little symbols are confusing to me. I wish it would say CD4 positive is minus. The lower it goes, the worse it is. Okay, here's a review question. You can give it a swing. So when does AIDS officially begin? You've got two different entities that dictate that. The AIDS Surveillance Task Force that does research and collects numbers includes everybody that has less than 200 CD4 plus lymphocytes. And in Wilkins, it's called early symptomatic HIV disease when they get to this less than 200. I'll give you the bottom line on these magic numbers here in a minute for testing purposes. But less than 200 CD4 plus is considered by AIDS surveillance to be the beginning of AIDS, when someone has gone from being HIV positive to officially being declared AIDS. Everybody that's HIV positive does not have AIDS. They have the AIDS virus, which is HIV, but they do not have AIDS until they are at less than 200 CD4 plus, according to AIDS surveillance. Okay, laboratories define AIDS earlier, and the reason that they do that, I would only be guessing, but I assume it's so that they are a little more aggressive in treatments, and where they're not just collecting data, they are treating patients, and their laboratory indications are what inform physicians as to the protocol for treatment. I would assume that they are going to be a little more aggressive and start treating this as AIDS at a higher CD4 plus count. Okay, they define it as 500 or more CD4 plus. And in Wilkins, this is called the acute seroconversion syndrome primary HIV infection. It's a lot of words, just know these two magic numbers here. You don't need to know which is called which. Okay, so let's talk about the incubation period here for a minute. It is defined as the point where, it's defined as the point where detection of the antibody in the blood occurs. And that term is called seroconversion. So seroconversion is defined as the detection of the antibody in blood. And seroconversion happens within the incubation period. And the incubation period happens within 6 weeks to 6 months after exposure. And the antibody presence does indicate infection, not AIDS, but HIV infection. And then throughout all of the stages of infection, including the incubation period, the viral production is high. There's a period early in the incubation period where the viral production is quite high and usually symptomatic. We'll talk about those here in a second. Going to the 6 weeks to 6 months after exposure, if you remember, this is why we have anyone that has a bloodborne pathogen exposure, needle stick for instance, go in and get tested immediately so that they can establish that if they test positive that day of that stick, that means that that transmission, that incident, was not what caused them to be HIV positive, because a needle stick that day would not be causing them to seroconvert within the day. It takes within 6 weeks to 6 months after exposure. And some of you have had to go through that, and it's a long 6 months waiting for word on if that exposure did indeed cause you to seroconvert. It's unfortunate, so we do everything we can to avoid those. Okay, the testing for HIV, again, some of you who might have already been tested, you're familiar with these tests. The gold standard is the ELISA test. It identifies the HIV antibody. Be sure on test questions that you know that it does not identify the HIV virus. That's a really classic board question that will try not to trick you, but to measure if you really understand the difference between what the ELISA test is measuring and between seroconversion and so on. This test identifies the HIV antibody, which will be being manufactured by the body in response to the HIV virus. So it's not measuring virus at all. Later, when we start getting into CD4 numbers, those are measuring something entirely different. So know that the testing for HIV, the ELISA, identifies HIV antibody, not virus, and that a different test measures viral load and CD4 plus counts. If you get a positive on an ELISA test, a second test is needed, and that's most often the Western blot. And the two together have a more than 99% accuracy. And we just talked about this on the last slide of why you might not detect a recent infection. For those of you who are struggling to answer this question, you need to think quickly back to the last slide. That 6 weeks to 6 months incubation period is why you might not detect a recent infection. You're not going to seroconvert in a day or even a week. Okay, as far as symptoms go, from the time of infection until evidence of AIDS symptoms, it may be 15 years or longer, so this can have a really long incubation period. And the acute seroconversion syndrome, as listed in Wilkins, is a series of symptoms that are flu-like or mononucleosis-like, and they appear in half of the infected within 6 weeks. You can see here this guy's got a really big lymph node. And here are some of the other symptoms: lymphadenopathy, fever, night sweats, pharyngitis, fatigue. Malaise just means overall general unwell being, just really worn out. Muscle pain, a rash. And then viremia, where this means you're getting virus, a high load of virus in the bloodstream within 2 weeks after initial infection. Okay, very high levels of virus, and these symptoms are related to that it is the body's starting to fight this back and to develop the antibody that will then later be seen in the blood test as this patient seroconverts. Your early symptomatic HIV is here, and we've talked about this already a little bit, but again, your CD4 positive or CD4 plus T lymphocytes between 200 and 500 and continued increased viremia. So basically this is saying your CD4s are starting to drop, but they're not to that 200 level yet. They're between 2 and 500, and as these drop, the viral load increases. And you start to see again some more systemic symptoms. And this right here is kind of a hallmark of HIV starting to be turning into AIDS or full-blown AIDS. Opportunistic infections start to begin. Why are they beginning? Because your T cells are dropping, and these are your fighter cells and your immune system cells. So as those drop, virus goes up. Opportunistic infections now have that opportunity to start to manifest themselves. And the oral lesions become more common, especially candidiasis. And then we have late stage disease AIDS. This is defined as the CD4 falling below 200. Okay, so I know that the task force has got their numbers, the labs have got their numbers. For our purposes and for testing purposes, know that early symptomatic HIV is the 2 to 500, and that late stage is the 200 or less. Okay, you don't need to know this big long name of this pneumonia. Just know that there is a particular type of pneumonia, along with some other AIDS-defining diseases that start to appear in late stage. One of those being Kaposi's sarcoma or Kaposi's sarcoma that you've probably learned about in pathology, and we have some pictures of later in this presentation. Okay, and then the presentation of full-blown AIDS really does depend on the host's other infections and what else is going on. It's widely varied. Clinical applications, you can read these. They're not earth-shattering. And these are just a recap of some of the things that we do that can help us to be alert to patients that might be HIV positive. I won't take time in this presentation to tell you my entire story of my first HIV patient. It was just, I suffice it to say, it was really humbling. I was in school. He was our only, at the time, HIV and AIDS had just come out. Magic Johnson had just announced that he was HIV positive. It was very, very scary. It was a death sentence to get. It was 1988. And my patient, I didn't want to see him, and my husband didn't want me to see him. And I was told that I really didn't have a choice. You can't decline someone for treatment. And so I saw him, and he asked me if I'd had extra coffee that morning because I was shaking so badly, and he knew that I was scared, and he just really helped calm me down. And I was able to see him for both of the years that he was there, that I was there in school. And I learned a lot from him. He passed away right before I graduated from full-blown AIDS. He was well underway with AIDS by the time that I saw him. And actually, I ended up treating his partner too. And just, it was a really humbling experience, and one that I learned a great deal, being able to see AIDS manifested in the oral cavity and in lives, and to just see how devastating it was. Anyway, on the risk factors, the way that we knew he was HIV positive, he disclosed that, which was really something he didn't have to do. But you won't have patients that will usually tell you that. We do have one patient in our clinic that is fairly regular, and he has disclosed that he's HIV positive. The rest of the patients that are HIV positive that don't tell you, you might recognize them if you see that they've got antiretroviral medicine that you've learned about in pharm, or recent onset of unexplained symptoms in HIV infection. I would doubt that you'll ever diagnose HIV status chairside. I don't think that's what business we need to be into. The IO-EO exam, the lymphadenopathy, the skin lesions we'll talk about here in a bit, herpes, purpura, and Kaposi's sarcoma, and then candidiasis are your main four. And those are listed here too, and hairy leukoplakia. Okay, most of the rest of these slides are just pictures, and we've already gone over candidiasis, but I want to point out a couple things that you want to pay attention to for the test. We've got 3 different candidiasis on this slideshow. The first is pseudomembranous, and note its location is mostly on the palate, tongue, buccal mucosa, and gingiva, and then that the surrounding mucosa may be red. So know that that's pseudomembranous. Just think membrane, it looks like a membrane. It's kind of white, yellow, white, plaquey looking. Okay, and here's some more pictures of it in its locations. This picture here is a final stage of AIDS. The next one is erythematous or atrophic. And just like its name, instead of looking like a membrane, like the pseudomembranous type, it's going to be really red. You can see this diffuse redness, most often found on the palate or the tongue. So if I'm describing the different candidiasis, one distinguishing factor between pseudomembranous and erythematous is the color, red versus kind of a yellow-white. Okay, there's some more pictures of it. And the treatment is antifungal for all of the candidiasis. If they're on nystatin, they know. I swear there was another candidiasis. Maybe there's just 2. Oh no, there's the other one, hyperplastic. And that's with the hair-like projections, and they cannot be removed. So here, this thickness on the tongue, this looks more like pseudomembranous to me, but just remember hyperplastic, just like dilatant hyperplasia, is a thickness, kind of a hyperkeratinization type of a look, and cannot be removed. Okay, and then we get to oral hairy leukoplakia. I'm not going to test you on this. I'm assuming that it's being well covered in pathology, but just know that it's the lateral border of the tongue and that it is one of the AIDS-defining oral manifestations, meaning that generally people only have it in severe immunocompromised states. It does have an Epstein-Barr virus etiology. Acyclovir is the medication for that. Again, I will not be testing you on this other than that it might show up as an AIDS-defining oral manifestation. Herpes is another one because they're immunocompromised. That is common. And then your HIV periodontal diseases, NUG, NUP. You're learning about these in perio. I won't be testing you on them again, except just, again, you need to know that they are AIDS-related oral manifestations. Not meaning that anyone that presents with them has AIDS. However, these are classic presentations of mouths with patients with AIDS. This is where you'll see them most. And human papillovirus. You can see here the little warty looking papillomas there. Kaposi sarcoma is the most common malignancy found in HIV positive patients. It is a cancer. It looks like bruising here. It recurs more frequently on the palate, the tongue, and the gingiva. And this is an AIDS-defining illness. If any of you have seen the movie Philadelphia, it was Tom Hanks played I think he was a lawyer who was HIV positive, developed AIDS. It's based on a true story, and he had Kaposi sarcoma on his face, and I believe that was what was the giveaway. It's been a long time since I saw the movie, but I believe that's what was the outward sign to everyone that he was AIDS patient. And here you can see that's what it looks like. Okay, so when you have a patient with AIDS, let's get down to the nuts and bolts and finish it up here. You will consult with a physician prior to invasive treatment, including root planing or scaling. You need to be determining a need for an antibiotic. So if you have a patient that discloses that they're HIV positive, you'll be telling them that you need to consult with their physician, not for permission to treat them. Don't act like they're a leper, but just let them know that you need to find out if there is a need for antibiotic prophylaxis to help them be able to fight their own bacteria as it enters the bloodstream when you're cleaning their teeth. So explain to them that, and the results of the latest blood count will show the CD4 plus cell count and the viral load. And if you remember, the lower this is, likely the higher this is. And the lower this is and the higher this is, the more advanced their HIV infection is. The more severe their symptoms and the more risk they are of infecting another because their viral load is high. Our one patient that comes to mind, his doctor does send his paperwork, and he is below 200 CD4, and his viral load is, I want to say, a couple 100,000. It's way up there, so he is progressing in his AIDS status. No, this term, and we've already talked about this, viral load is inversely proportional to the CD4, and then 10,000 to 50,000 viral load is significantly high, and they should be on medication. The physician will surely be over this. We would expect them to be on medication if they're this high. Okay, and then our universal precautions, we treat them the same as we would anybody, regardless of their known HIV status. We're assuming everyone has everything that we don't want. Have them pre-rinse with chlorhexidine instead of Listerine, just because it does last a little longer. That substantivity is high with chlorhexidine. And plaque removal, especially if they're immunocompromised, the lower the bacterial count in the mouth, the better. So having them understand the importance of keeping their mouth clean as helping them toward remaining healthy and not having some secondary opportunistic infections is helpful, and a 3 to 4 month recall. Okay, and so that ends the presentation here. And if you have any questions, we're going to have time to, next week when we meet, I will answer questions about any of this material. So just jot them down if you have questions and write your notes. You can put your notes down in this area of the PowerPoint that was prepared and posted on Canvas. Thank you.